as well as their mean satisfaction scores were improved. This is an example of looking at things from an operations management perspective, because I think it's very important from a navigation viewpoint to not just look at each patient individually and fix this problem, but also to look at this from an operations management perspective and see what is the frequency with which this particular barrier is happening? What is the frequency with which this particular issue is coming up, preventing a group of patients that you're taking care of from efficiently traveling through the system and getting the care that they need? So this actually is looking at Hopkins and at something that I took a look at a few years ago. Our old process was that we had patients scheduled for surgery, say on April 21st. Surgery was performed on the 30th. Pathology results were back on the 5th. Patient was seen for a post-op appointment with the surgeon on the 6th. Patient was then scheduled for a medical oncology consultation, which we were not able to arrange until 20 days later. And then that consultation took place, and then a week after that, her chemotherapy began. What I thought was important for us to do was to expedite getting her in to see the medical oncologist. Because once you say to a patient, yes, you probably are going to need chemotherapy, or gee, you have several nodes that are positive, so I think that you should anticipate chemotherapy getting underway. If you then turn around and say, well, it's going to be a few weeks before they can get you in, that's not good. It's not good for anybody. So at the time that the patient is scheduled for surgery, we automatically make arrangements to also proactively schedule her for a medical oncology consultation. Whether we think she needs chemotherapy or not, we're holding and reserving a slot for her. So by doing so in this case, it was pre-booked to be on the 13th. She had her surgery, pathology came back, she had her post-op appointment, and I'll also tell you that we place on the left-hand side of the medical record for the surgeon a printout that tells him or her the exact doctor being seen, which medical oncologist it is, and the date and the time, and if it's at our downtown location or a suburban location. So when I go in with one particular surgeon that I work alongside with, I see that he'll look at that and then close the record and go in, examines the patient, pull her drains, whatever it is that we need to do, reviews her pathology, and then we'll go, if I recall correctly, I believe you're seeing Dr. Wolf next Wednesday out at Green Springs Station. And of course she looks at him like, I'm the only patient he's taking care of, for him to remember all those details about me, when actually it's that little cheat sheet that's on the inside. But its timing is everything, and so we refer to these appointments as just-in-time medical oncology and radiation oncology appointments. But you see that it speeds up getting her chemotherapy underway, speeding it up by several weeks and reducing her anxiety as a result. Another research study of interest was with a minority group of women in Atlanta, Georgia, and their mission was to reduce mortality. The results, as a result of their navigation program, which was measured during the period of 2001 to 2004, they wanted to see if they could increase the frequency with which patients with DCIS were diagnosed by bringing them in for screening mammography, and that number went up from 12.4 to 25.8% having stage 0. And they wanted to see a reduction in stage 4 breast cancer patients with metastatic disease, which went down from 16.8 to 9.4. There also are some resources and tools now available to navigators. There's navigation software that can be used to help track all of this information. There's also a certification program conducted still by Dr. Harold Freeman in New York. The National Consortium of Breast Centers also has developed a program specific for breast care and breast cancer, and it is designed for nurses to become certified. And there's organizations for support services for patients. One in our area is the Red Devils that provides free transportation for our patients. Anyone who cannot afford their hormonal therapy prescription, they will pick up that prescription for the entire length of time that they are going to be receiving that medication. They also provide food for the patient and her family throughout her treatment, and send Mary Maids in to clean her house every other Saturday. The commitment to our patients is something that we've also felt. I think that's been pretty palpable these last 2.5 days together. But I just want to reiterate that everyone involved with a cancer patient has some degree of responsibility to facilitate that patient across the continuum, identifying barriers, helping to resolve those obstacles, and educating the patient and providing support. So what happens when the patient is done her treatment? And that's something that we haven't talked a lot about yet, but is something worthy to touch on, I think. In looking at the United States, it is projected by the year 2020 we will have a 48% deficit in oncology specialists taking care of cancer patients. And that also has been mapped out looking specifically at breast cancer, estimating it to be a 41% shortage, which means that oncology specialists will not be able to follow patients after their treatment long term. I know for years I would say, I'm going to be seeing you for the rest of your life. And I can't say that anymore because I won't be. So establishing those expectations up front as to what her treatment plan is going to look like, but also what her aftercare follow-up is going to be is something that we need to build into this. And I think that that's where a navigator can have a very valuable role in assisting with transitioning that patient over to a nurse practitioner team, which is something that we've done at Hopkins, as well as then from that NP team back out to the community doctors, her PCP and her GYM, and making sure that those individuals in the community have the information that they need in the form of that summarized treatment plan and what's the to-do list in taking care of that patient going forward. So where do you start? And you start by performing an operations management on the current clinical processes. You want to measure what the delays in the diagnosis and treatment are and observe by walking alongside one of your patient and not interfering with any bumps that you see that are not functioning in an efficient way. You're just going to record what you see, but that becomes your template for where you're going to start. Some of the key components to that implementation is easy access for screening and diagnostics as well as treatment, rapid results from tests, whether those be x-rays or pathology, rapid